Good morning. Our lecture today is about periodontics with other aspects of dentistry. Periodontal restorative interaction. The biological width is defined as a dimension of the soft tissue which is attached to the portion of the tooth coronal to the crest of the alveolar bone. In this picture, we can see A, it is the histological sulcus, while B is the epithelial attachment, which is the attachment of the epithelial to the tooth surface, while C is connective tissue attachment. The biological width is B plus C, which means the epithelial attachment 0.97 plus 1.07, which is the connective tissue attachment. The total width should be 2.04 millimeter, which should preserve the biological width and should be away from the bone. As you can see in this picture, the junctional epithelium and the connective tissue attachment perform the biological width. This distance should be away from the crest of the bone. Why should we preserve the biological width? Biological width is very important for the preservation of the periodontal health status and the removal of irritation that might damage the periodontium. Any prosthetic restoration, any crown should be away from the crest of the bone. The millimeter that is needed for the bottom of the junctional epithelium to the tip of the alveolar bone is very important because it is responsible for the lack of inflammation and for bone preservation and prevent bone resorption. That will lead to the prevention of development of periodontitis. إذا لازم دائما احنا هاي المسافة نخليها ببالنا انه تكون بعيد عن الكريست اوف ذا بون ونحفظ البيولوجيكال ويدث على مود نحافظ على البون و to prevent the development of periodontitis. There is a variation in the biological width from patient to the patient. The average is 2 mm لكنه طبعا تختلف من patient إلى patient. يتراوح الاختلاف من 0.75 إلى 4.3 mm in different individuals. How you can evaluate the biological width? There is a clinical method which is bone sounding and the radiographical evaluation. There is signs of biological width violation. يعني يجينا البيشنت احنا نعرف اكو فد violation للbiological width. There is a chronic progressive gingival inflammation around the restoration, bleeding on probing, localized gingival hyperplasia with minimal bone loss, gingival recession, pocket formation, clinical attachment loss, and alveolar bone loss. How you can evaluate the biological width through bone sounding? The biological width can be identified by using a probe, and we give the patient local anesthesia, and touching the bone level and subtracting the sulcus depth from the resulting measurement. If this distance is less than 2 mm at one or more locations, a diagnosis of biological width violation can be confirmed. There is also a radiographical evaluation, but you know that radiographs are not diagnostic because of the superimposition. But so Shama and Guri have described a new innovation, which is a new profile radiograph. استخدم radiograph to measure the dimension of the dentogingival unit, as you can see in this figure. The biological width, there is different in the types of the crest of the bone, either normal or high crest patient or low crest patients. يعني مو كل البيشنت الكريست اوف ذا بون البوزيشن مالتها تكون بنفس البوزيشن، ممكن عندنا نورمال، ممكن هاي، ممكن لو. normal crest patients تقريبا we can find these in 85% of patients, thank God this is found, and the gingival tissue tend to be stable for a long time in this case with any type of appliance، يعني with the prosthetic crown، يعني دائما هذول اللي يكون lucky patients. While high crest patients, it is found in 2% of patients and occur more often in the proximal surface adjacent to the edentulous site. While low crest patients, it is only in 13% of patients, and the patient is more susceptible to recession secondary to the placement of the يعني any restoration. The importance of determining the crest category is very important because this will allow the operator to determine the optimum position of the marginal displacement. And also to inform the patients of the probable long-term effect of the crown margin on the gingival health and aesthetic. How you can correct the biological width? Correction of the biological width violation could be either surgically or orthodontically. Surgically, by removing the bone away from the proximity to the restorative margin. In this case, we either use a flap or surgery by using a crown lengthening, and there is a high risk of interpapillary recession. You should put this in your consideration. While orthodontically, by using the extruding of the tooth out of the socket by orthodontic appliance. There is an indication for the surgical method, which is the crown lengthening, either in case of inadequate clinical crown for retention due to extensive caries, subgingival caries, or tooth fracture. إذا عندنا short clinical crowns، إذا عندنا نحتاج أن نخلي subgingival restorative margins, unequal, excessive, or unesthetic gingival levels for the aesthetics, teeth with excessive or unesthetic gingival level for aesthetics, teeth with excessive occlusal wear or incisal wear اللي عندهم attrition abrasion، هذول أيضا راح يكونون short clinical crown. restoration which violate the biological width نسوي لها correction، نستخدم هاي كلها كindication of the crown lengthening. There is contraindications for the crown lengthening. First, in deep caries or fracture requiring excessive bone removing, and in that case we need to open a flap. Post-surgery creating unesthetic outcomes. In case of tooth with inadequate crown root ratio, non-restorable teeth, tooth with increased risk of furcation involvement. In this case, we should clean the furcation area by using surgery and open flap. Unreasonable compromise of aesthetic and unreasonable compromise on adjacent alveolar bone support.